If I talk into it? Okay. Thank you, Phyllis, and I've enjoyed your support and working with you over the years, too. Phyllis is also very good at coming up with catchy titles for presentations. So Mommy Dearest is not my... It makes you think of Joan Crawford beating up her daughter. And this is hardly the image I wish to present today. So most women want children, although it's a perfectly viable option to decide not to, and there's lots of other ways to be happy in life, as research shows. Most women do have children, and those who have children are generally glad that they did. So what's the problem? Well, large-scale epidemiological studies going back many years have shown that women in particular have a peak of psychiatric symptoms between the ages of 20 and 40, which is the same time when most of them are having children. And that life gets better after 40 and 50 and 60. And the idea that it's better to be young is completely untrue. It's hard to be young, and it's much better to be middle-aged. And maybe there could be many explanations for this, but one is that raising children is not easy. And it makes me think of the work of the feminist sociobiologist Sarah Blaffer Hrdy, who wrote several books about mothering, which are quite terrific. And Sarah Blaffer Hrdy's basic thesis is that women used to raise children in a community with other women, with grandmothers, aunts, sisters, all kinds of other people, and that the raising of children in traditional society through most of human history was a communal activity. The idea of living in an apartment and raising a child and not knowing too many people, as happens to many mothers today, is a very abnormal situation, and it may help to explain why parenting is difficult in the modern age, as a number of other things are. But the topic of my talk is about parenting and mental disorder, and we'll come to more specifics as well. I'm not sure about this Yahoo. All right, it's gone. The first, to put it bluntly, is that children are naturally selfish, and they should be. They're there's no reason to expect children to think of their parents' welfare above their own, or that of their siblings above their own. It takes many years for children to become generous, to have a perspective, a theory of mind, all of these things. And so young children don't automatically love their parents and give them love. So this is a problem for people who want to have children in order to be loved because nobody else loves them. And that's a lot of what we see in psychiatric populations. Second point, to repeat, is that raising children requires great sacrifice. You have to put yourself second or maybe third for many years. So it requires some degree of mental health to be able to do that. And then, of course, and this was brought up before, parents need partners, and then they also need extended family, and they need social supports. And it can be very isolating to spend all day with a small child. So these are some of the problems that may be particularly challenging for women with a diagnosable mental disorder. On the other hand, it's possible that people get better when they have children, even though they've had trouble before. If there's something positive about being able to take that responsibility and to master it. Every mother wishes to have a better childhood than they had, and many succeed in providing a better deal for their children than they experience themselves. You have a social role, you have a purpose in life, and even though children may be selfish, it's still an attachment, it's a safer attachment for many people than pair bonding. Now, I'm going to talk about personality disorders. This is what my research career has been about, and I have to always explain what it means because you say depression, you say anxiety, everybody knows what that feels like, but you say personality disorder and people say, what is that really? Everyone has a personality. A personality disorder could be described as a personality that doesn't work, and it really doesn't work in a big way. But the boundary between disorder and just being different is not always obvious. So we do diagnose people with personality disorders who have complex problems that begin early in life and last for many, many years. In other words, this differs from an episode. So often people who have long histories of problems in life come in with depression, and psychiatrists say, well, you're depressed, and that's the end of the story, of course, because they want to go straight to the antidepressant prescription and not think about more complicated stuff. But in fact, people with personality disorders often get depressed, but that's only part of a long-standing problem. So they have troubles regulating their emotions, controlling their impulses. They have trouble in relationships. They don't get along with other people. They break up with their partners. They also have cognitive problems, dysfunction in work as well. And so even if they have depressive episodes and maybe substance abuse on top of that, the personality disorder is the big picture. So that's what I've been interested in. And I think having been trained with the Jewish general is what got me into this subject, not because our personalities are more difficult than anybody else, but because this department has traditionally been one where people are interested in that big picture and the life trajectories and all these things. Now, the best studied and the most clearly defined of the personality disorders is called borderline personality disorder. And many people are going to say, well, what's that too? I mean, borderline doesn't mean anything. There's no border. We just don't have a better name for it. So what are we talking about? We're talking about people with notable affective instability. Now, this is not bipolar disorder, although unfortunately every patient with borderline personality disorder gets called bipolar these days because doctors want to give medications, I believe mistakenly. Affective instability means that your mood is affected by your environment. It bounces around. The patients say they're on a roller coaster. Every hour they're in a different mood. This is not a hypomanic or a manic episode. This is a completely different phenomenon, and it's quite characteristic of these patients. So already you can see that's something that might interfere with parenting. Similarly, impulsivity, which takes specific forms. If you worked in an emergency room, you'll know these patients. They come in with overdoses after a quarrel with somebody. They cut their wrists often regularly for years. They go into rages where they lose control of themselves and may use substances as well. So they have a broad pattern of impulsivity. Again, not good for parenting. Relationship problems. They tend to get attached to people too quickly. They get into fights with all kinds of people. They break up a lot. They have a very unstable relationship pattern. And many of them also have slight paranoid trends and what we call pseudo-hallucinations. They hear voices, although they know that it's their own mind talking to them. So that's borderline personality disorder. How common is this condition? Well, we only had epidemiological studies in the last decade, and most of them come up with something about 1%. That's a lot of people. That's the same as schizophrenia. And the surprise was that most of these studies showed it's equally common in men and women, because that's in the community. And that's not what we see in the clinic, where we see a lot more of these patients in clinical settings, and most of them are young women. So where are the men? Maybe they don't ask for help. Maybe there's something wrong with these numbers. I'm not sure what the answer is to that. Now, I am best known for a paper I published in 1987, and nobody has, none of the papers I published since has had the impact of this early paper that I wrote at the beginning of my career, supported by a small grant from the Jewish General Hospital Department of Psychiatry, where we followed patients for 15 years with borderline personality disorder, and later on we looked at them again in the late 90s, after 27 years. But there's a lot of other people have also done studies on this. There's about 5 or 6 different research groups, and they all came to the same conclusion, which is that most people with this condition get better, and that's the explanation of why these women are young, because by the time they're 35 or 40, they get better. In a major prospective study done by John Gunderson that was in the Archives of General Psychiatry last year, only a minority failed to remit, although you can't say they were absolutely normal, but they didn't have this, certainly didn't have the same extent of problems as they got older. And so they had certain difficult traits, but their symptoms went away. 5 to 10% of these patients do commit suicide, so that's bad news. But the good news is that most of them don't commit suicide after threatening to commit suicide and scaring everybody in the emergency room and the outpatient clinics and the CLSCs for years, saying that they were going to kill themselves. Most of them never do. In fact, most of them, when they get better, they're no longer chronically suicidal. They stop thinking about it. Now, what's that got to do with mothering? Well, many of them will never think of suicide again when they have a child. End of story. I would never do that to my child, period. And so they automatically are better. Also, many of these patients don't have children. We found, and this was supported by other groups, that only half of them ever became mothers. Quite a few of them didn't live with partners. They developed careers. They lived the life of single women. They found other things in life, and they didn't have the need to have children, or it just didn't happen. Now, what about those who do have children? So I said that many of them will give up their symptoms, and in general, it's been found that people who have children commit suicide much more rarely than people who don't. So what's happening here? My clinical impression is that these mothers put their children first. And they also will stop using drugs for the same reason. Now, what about, and I think that's true in most of the cases. It certainly was true in our outcome, in our big follow-up study. However, maybe some people are not successful at doing this and get into trouble and end up in youth protection services. And it's possible that those who recover may have more subtle problems, do not come to clinical attention, but if you continue to cut and overdose and have crazy relationships and use substances, you may well come in contact with the youth protection system. So if you think about it, the features of borderline personality disorder don't help. Your emotions are unstable, you're impulsive. How are you going to parent? You're going to be very inconsistent. Maybe even a consistently depressed mother would be more predictable for a child than somebody who was in a different mood every day or every few hours. the lack of a stable partner, and the presence of abusive partners, because some of these patients have an absolute eagle eye for psychopathic men, is another problem. Some of them over-involved with the child, don't have any friends, try to use the child as a friend, and this tends to blow up at puberty when the kid wants to separate. And some of them may come from dysfunctional families and lack parenting skills. Okay. Now, we first looked at this here in this department in 1995. Margaret Weiss was with us at that time, and Phyllis Zelkowitz was a collaborator on this project. At the time, we were doing a large-scale project with women with borderline personality disorder, and comparing them to mothers with women with other personality disorders, and some of them had children. Actually, a minority, but some of them did. So, it wasn't a big study. But what we did find was that these children had more psychiatric diagnoses, particularly impulse control disorders. Some of them seemed to were similar to things which have been described in borderline personality disorder, but more like children. I mean, children don't overdose and cut, but they can certainly be unstable and impulsive. And they were functioning more poorly. So this was kind of a pilot. We didn't follow it up, and there wasn't a lot of work on it for many years. And it's only recently that people have started to look at this again. The paper I gave to you by Jenny McPhee from the University of Tennessee is a review paper in your package. It says there were 5 studies. I found a few more than 5, but not much more. And you might see at the very end of that paper, McPhee says, this is an area which is sort of uncharted territory. So we have small studies, pieces of data here and there, sort of pointing in the same direction. Crittenden Newman, that's a group from Australia, found abnormal attachment patterns in children whose mothers had borderline personality disorder. Just this year, STEP had a sample, and she just was looking more at the parenting behaviors, which were sort of inconsistent, either control or aloof. Barno and Ahrens last year went to the community and looked at borderline traits, which is not the same thing as borderline personality disorder, but she found it was strongly associated with similar traits in children. Hare et al. In 2008 increased symptoms in adolescent children of women with BPD. Jenny McPhee herself published some narratives of dysfunction in children with borderline personality disorder, so qualitative research. Hobson used a strained situation. You may be familiar with that. This is when the mother leaves and somebody else walks in, and you see how the kid reacts. And it's a standard measure based on attachment theory, and you can see abnormal attachment patterns even in 1-year-olds, and this is what they found. White et al. Also thought that they weren't well attached to their infants, and a poor response to infant distress. So these are fragmentary data, but it's interesting how many people have gotten interested in the subject, and that there is some sense that it might point in the same directions, i.e. problems of responsiveness to the child, maybe problems in separating from the children. That hasn't been looked at that much, but certainly some kind of inconsistency in parenting. Now, I'm working with Lise Laporte, is a psychologist at the MUHC, who works part-time at the hospital and part-time with Centre Jeunesse, so she's very involved with youth protection services. And Lise Laporte is the brains behind the current project, which also includes me and Phyllis Selkowitz. And I don't think we would have gotten the grant money without you, Phyllis.
I don't know about that.
Right, but we have gotten some money from CIHR to look at this. Now, the question is, how much personality disorder, and particularly borderline personality disorder, is there among women and youth who are being followed in youth protection services? Now, a guy by the name of Truck May, who is a big expert in the school, and he's in the School of Social Work here with Sharon at McGill, had a survey where there might be as many as 40% with personality disorder. Well, that's not really very surprising in a population of women who would be involved with youth protection. Okay. Rudder many years ago thought that mental disorder in parents might not be that hard for children to deal with unless they were angry, hostile, critical, and unfortunately that's sometimes what we see in some of these mothers. So this is our study which we're conducting right now. It's sort of a preliminary study, and we have gotten the cooperation both of Batshaw, the English Youth Protection Agency, and the French one, Centre Jeunesse. And we're reviewing 300 charts to establish the frequency. It looks like preliminarily we might be finding 20 to 25% of these women have borderline personality disorder, but it's too soon to be sure of that. We have some, but we're actively doing this. We have 2 excellent research assistants, one of whom is here today. They have been trained to do the chart review, to make the diagnosis, and also to interview a subsample using standard methods, and then we'll do a qualitative survey as well. We'd like to look at the children of these mothers, but that would be and to examine the psychopathology in them, but that would be a future stage which would require another study. But we are hypothesizing these clients will have more problems in parenting, that children will have more symptoms, and that these symptoms may be similar to those that's seen in the mother, i.e. affective instability and impulsivity. Now, you get in most of the people who are involved with YPS, interestingly enough, and I didn't know this until I got into this area, are not being accused of child abuse. That is a minority. The vast majority of cases, it's neglect we're talking about. Now, we're not talking about the kind of neglect where you don't smile at the kid or approve of them. We're talking about the kind of neglect where you disappear and leave them alone for, yeah. And so, given the fact that abuse and neglect is common at BPD, people have raised the possibility of intergenerational transmission. Nevertheless, and I reviewed this literature in the 90s, most children who suffer abuse and neglect, even severer forms, are resilient. And it's interesting that you can't say that people with psychopathology must have been mistreated as children. I mean, psychiatrists have done a terrible job of blaming mothers for the last 50, 60 years.
They've done a good job.
Yeah, right. Children are resilient, and they have to be. And most children, even in bad circumstances, do grow up to be normal, and I hear wonderful, heartwarming stories. Also, many patients with borderline personality disorder have never been abused as children. It's a subgroup. So this is an association which has been vastly overblown. Okay. So in summary, personality disorders, especially borderline personality, could interfere with mothering, particularly if the disorder doesn't remit after children are born. That could lead to involvement with YPS. These mothers are probably have a more severe form of borderline personality disorder than most of the cases we see. What are the implications of this? Well, personality disorders needs to be recognized and treated. One of the ideas behind our study is to educate and have knowledge transfer so that workers in the youth protection system understand and recognize these problems, and this would help them to address some of the parenting difficulties. And we could have a collaboration between professionals and YPS workers, because it's a very difficult clientele. But again, caveat, I had one lawyer for Batshaw call me trying to drag me into court, which I resisted verbally over the years, and said, but you've diagnosed this woman with borderline personality disorder. How can she be a good mother? Well, the fact is many women who've had these problems are good mothers. It's a subgroup that isn't. So the diagnosis shouldn't be stigmatizing, but you have to look at specific behaviors and specific issues. Thank you very much.